Well, welcome back, everybody. We'd like you to take your places for the second presentation. If you'd be able to move back to the room, and having enjoyed a beverage and a snack, we hope you're ready. We'd like to welcome Nicole Allcock, who is a Doctor of Pharmacy, which she received that degree from the University of Missouri, Kansas, and her residency training was in critical care and infectious disease. She has practiced in the medical intensive care units at the University of Chicago, right here, close to home, and the University of Missouri hospitals, and was a clinical assistant professor with the UMKC School of Pharmacy. She has many other credentials that she brings to this conversation. She and I were talking just beforehand about how important these interdisciplinary relationships are today, particularly, of course, with critically ill patients, but just as pharmacotherapy becomes more complicated and the management, I have a background in internal medicine, we have so many people on polypharmacy, but also then there's these important ethical questions that come up both in the practical clinical practice and the matters of conscience for the pharmacist themselves. So we look very much forward to hearing her presentation. I'd ask you to give her a hand and welcome her to the podium.
Good morning. It's good to be back in Chicago. We lived here while my husband was in medical school, and I worked at the University of Chicago. It was my first job after residency. And last night, as I was in the cab on the Eisenhower not moving, I remembered that was one of the reasons we left Chicago. My idea of rush hour traffic now is getting behind a tractor on the way to work. So right now we live in Cape Girardeau, Missouri, which is our hometown, about 2 hours south of St. Louis. And though I have a background in critical care medicine, I've kind of moved over to what some people would refer to the dark side. I'm now the Director of Pharmacy at a community hospital in Cape Girardeau. And that hospital is not a Catholic hospital, so I do want to disclose that what I'm speaking about today does not necessarily represent the views of my employer, but we'll get started. Today, it's going to seem like I'm jumping all over the place a little bit, and actually before we get started, can I see how many people in the audience are either pharmacy students or pharmacists? So I get an idea. A few. Okay, one. Well, then we'll go about this from the aspect of what the pharmacist has to deal with, but also how you can interact with pharmacists on your team. We're going to discuss a few of the cases, religious liberty cases, court cases that have happened with pharmacists, and Illinois was a big area for one of those. We'll discuss the current legislative agendas affecting pharmacy practice. I'm just going to give some examples, especially in Missouri. I serve on the Public Policy Committee for the Missouri Conference of Catholic Bishops, Missouri Catholic Conference, so I get to see a lot of these bills before the rest of the public really knows they're out there. And we'll talk about policies of our professional pharmacy organizations and how they may or may not help us in our cause for religious liberty in pharmacy practice. And then we'll go over a few issues of conscience in everyday practice and how we can minimize cooperation. So we've all seen some of these headlines, and they're typically sensationalized and almost always have to do with emergency contraception because that's what's in the news. You'll notice that most of these headlines I have on here from 2004. This is when this topic really came to the public eye. Plan B was still a prescription at that time, and I was practicing in Illinois. I'm still licensed in Illinois when we all got this letter in the mail from Governor Blagojevich, Dear Illinois Pharmacists and Pharmacies, basically saying you must dispense emergency contraception. Actually, it said all valid prescription at that time, which then there was a big argument of, well, we have clinical decision making and that sort of thing. But with regard to contraception itself, the governor actually came out later in a statement and said, yes, I was specifically targeting those people with religious beliefs, and the pharmacist should get another job if they don't want to do that. So this letter came to us in the mail, and now that I'm interested in ethics, I kind of wish I'd kept this letter, but I think at the time I was so angry I did something like burn it. I don't remember exactly what I did with it. But the other interesting thing with this is it really pitted physicians against pharmacists, because it gave the physicians a hotline number to hotline pharmacists who didn't comply with whatever prescription they had written. So obviously after that, pharmacists started filing lawsuits. And the most public of these lawsuits, I believe, was filed in 2005 by pharmacists Vanderbleek and Kasserag. They owned some pharmacies and did not want to dispense emergency contraception. This case was initially dismissed, but that dismissal was reversed by the Illinois Supreme Court, and then they went through years and years of litigation. Finally, in 2011, the court found that the emergency rule, or the governor's rule, was found to violate the religious liberty of these pharmacists, and they cited these laws in the reasons that case was found to be that way. So the Illinois Healthcare Right of Conscience Act, Illinois RFRA, or Religious Freedom Restoration Act, which of course is Illinois' version of what we've been hearing about so recently in Indiana, Arkansas, and other states, as well as the U.S. Constitution. In September 2012, of course, the state appealed. So in September 2012, the state appellate court said again that the rule cannot be enforced against the defendants in the case, and the Illinois Attorney General finally decided not to appeal the case. And of course, at that time, Governor Blagojevich was going through all of his legal troubles. So that was interesting. So we won in Illinois. In Washington State, however, this case is still going on, and this will be the last case I highlight. In Washington State, this is really interesting because in 2007, the Washington State Board of Pharmacy issued a rule that would require pharmacists to stock and dispense emergency contraception. And I started researching how did this really come about, and what I found is that the Board of Pharmacy really didn't want to make that rule, but they were lobbied by both Planned Parenthood and other pro-abortion advocates. They initially rejected writing that into the rule, and they were pressured by the governor to do so. So after this happened, pharmacies started seeing test shoppers. It was not real patients, but actually people coming in, setting up the pharmacies trying to get emergency contraception. And that's how this case ended up forming, is that a test shopper came into the pharmacy owned by the Stormans, and when they wouldn't fill the emergency contraception, the test shopper then turned them into the state. So again, so far in this case, the pharmacy and the pharmacists are succeeding. In February of 2012, the rule was struck down by a federal district court, and it was appealed by the state and Planned Parenthood, and as recently as November of last year, oral arguments were heard in the Ninth Circuit Court of Appeals. And I don't know, I have not seen if that's actually been, it has not had an outcome yet. Although, interestingly, I do believe that the Stormans have been forced to pay $140,000 of the legal defense of the other side because of some costs that it cost that side to get some documents so that they could prove, the Stormans could prove their case. So do right of conscience laws protect pharmacists? What I've found is that these laws vary by state widely. Many of them do not explicitly include pharmacists in their laws. They include physicians, and it might say other healthcare providers, but are pharmacists considered providers? And most of us in this room would probably say, of course, pharmacists are healthcare providers. But when we think of what is a provider as defined by state law, some states may not consider pharmacists as providers. And then some right of conscience laws are directed specifically toward contraception and abortion, but don't include other types of therapies. So just want to go over an example of what's happening in Missouri right now, and these same types of examples are happening in other states. But we have House Bill 350, which has been put on the table. Unfortunately, it's not going to go anywhere this year. But this bill would require a pharmacist to fill all contraception, so it would include emergency contraception, since that's how it's labeled by the FDA, or they would have to order it immediately if they don't have it in stock. So basically the same thing that Governor Blagojevich put out. Like I said, this isn't going to go anywhere, but I think as pharmacists, we have to look at all of these bills that are proposed every year, because they keep getting proposed year after year after year until they get some traction. Missouri doesn't have a right of conscience law right now. House Bill 432 would be that right of conscience law. This is the 4th year it's been filed, and it has not moved at all, and I don't think it will go anywhere this year either. But this law gives the right not to participate to medical professionals. That's how it's defined. But then when you look at the very introductory part of the law, it defines what is a medical professional. What does that mean in this bill? And it lists many different professions. It does not list pharmacists. It lists physicians, nurses, nurse practitioners, probably 12 or 15 different professions. Nowhere does it say pharmacists, and nowhere does it say other healthcare providers. It simply lists, picks out certain specialties. So under this right of conscience bill, my interpretation is that pharmacists may actually not be protected. And what I've kind of heard through the conversations with some of my legislators is that it may have actually been designed that way, which is very interesting. So I've been in contact with the bill's sponsor and my own legislators on this one, and hopefully when it gets reintroduced next year, we can change that. So I said, are pharmacists considered providers? These bills in the United States Congress really don't have anything to do with ethics or conscience, but it's interesting that if you're a pharmacy student, you've probably heard of the pharmacist provider status bills, which are 592 in the House and 314 in the Senate. And what this would do is amend the Social Security Act to recognize pharmacists as Medicare Part B providers when they're working under their state scope of practice. So this has more to do with, are we getting paid for our cognitive services and access to healthcare in rural areas where a pharmacist may be able to provide some care. So I'm reading this thinking, would this affect conscience laws? And I'm not an attorney, I don't know, but I think it would, in those states where they list other healthcare providers in their conscience law, if this gets passed, I would think they would have a hard time saying that a pharmacist is not a provider. So I'm hoping that that might be kind of a roundabout way of solving some of these issues. Let's talk a little bit about the pharmacist lobby, because how do we get ourselves protected or into these laws? The professional organizations in the United States are not, of course, responsible for our regulations, but when you see APHA is American Pharmacists Association, ASHP is American Society of Health System Pharmacists, and those are probably the two largest pharmacy organizations that have lobbies on the federal level. Professional policy is developed in these organizations through the Board of Directors, the House of Delegates, and I've been a member of the House of Delegates for ASHP for enough years now that I can't remember. I think it's 9 or 10. And what these organizations do, they develop their professional policy, and then that professional policy sets the legislative agenda for what they are going to go advocate for to either Congress or the National Association of Boards of Pharmacy, or maybe even to ACPE, which is the accrediting body for pharmacy schools. So what these organizations do is actually pretty important. So let's look a little bit let's look at what ASHP, the American Society of Health System Pharmacists, says about conscience. So they have policy position 0610, which means it was written in 2006, called the Pharmacist's Right of Conscience and Patient's Right to Access to Therapy. So it starts out pretty good. It recognizes pharmacists' right to decline in therapies that they consider ethically troubling. And it goes on though and says that we should support establishment of systems by pharmacists to protect the patient's right. And then in the last paragraph, it talks about pharmacists, in their view, should provide a referral. So I'm sitting in the House of Delegates in 2006, having no ethics training whatsoever, and I'm thinking, I don't like that word referral. What does that mean? And just Dr. Perucci mentioned that kind of gut feeling sometimes, and so I'm sitting there, my gut feeling is, I don't like the word, I'm going to vote against this. So I did vote against it, but I'm a young pharmacist at the time, didn't really speak up too much, and of course, you know, it passed. In a minute, we'll talk a little bit more about referral, but first I'm going to tell you what APHA's says. APHA's does not, I don't know what that is. APHA's does not mention the word refer, but basically it's the same otherwise. So what is referral? And I know this is really simple. Let's just go to the dictionary. And so I went to the dictionary. What does Merriam-Webster say about referral? It says to send someone or something to a particular person or place for treatment, help, or advice. So that means if I refer, I'm choosing where that patient is going to go. So I'm choosing to send them to someone else who I know is going to provide that therapy that I consider unethical. In contrast to refer, what does it say for the word transfer? So transfer, to convey or cause to pass from one person, place, or situation to another. So a little less specific, I think, and these are just dictionary definitions, but in a way it conveys what we're trying to get is the difference between referral and transfer of care. So transfer of care may involve the same physical actions as a referral, but if we as a pharmacist can transfer care, then the pharmacist is not deciding or specifically directing the patient to another specific provider. And we'll get into some examples of that here. And when we talk about referral, we're really going to have to talk about cooperation with evil and different levels of that cooperation, because that's what we're talking about. As pharmacists, we're typically not the principal agent, but we oftentimes are put into situations where we have various levels of cooperation. So I like this definition of cooperation with evil. It comes from the NCBC's Healthcare Ethics Manual, and cooperation is the free and knowing assistance of an individual or institution in an immoral act performed by another individual or institution. Basic definition. And over the course of many centuries, the Catholic moral tradition has developed guidelines for different levels of cooperation or degrees of cooperation. So we'll talk just a little bit about that. And really what it's based on here is formal versus material cooperation, the concept of does the cooperator share the intent of the act with the principal agent. So with formal cooperation, the cooperator, which in this case would be the pharmacist, would share the intent of that act. And in material cooperation, they do not share the intent. Go a little further into the difference between immediate material cooperation and mediate. With immediate material cooperation, the cooperator, or the pharmacist in this case, provides a service or circumstance which is essential for the evil act to occur. With mediate material cooperation, the cooperator provides the service or the circumstance, but it is not necessarily essential for the essential for the evil act to occur. So the act itself could help without the cooperator's help, could occur without the cooperator's help. Proximate versus remote is getting into some details, but has to do with how far away from causing the act the person the cooperator is. So let's take a case, and we will take the case that everybody hears about in the public right now. John is the owner and pharmacist on duty at an independent community pharmacy. He does not stock emergency contraception. A patient presents with a prescription for Ella. And for those who aren't familiar with what that is, it's ulipristal, which is a progesterone agonist antagonist, which is used for emergency, or labeled for emergency contraception in the United States. Let's take a couple different scenarios of how this could go. So in scenario number 1, John tells the woman that he cannot fill the prescription, but he knows that pharmacist Sally at the pharmacy a few blocks down the road will fill the prescription, and even offers to call her ahead of time so she can get it ready. So this is probably what our professional organizations and some state laws are referring to as a referral. What really does that mean? Is this formal cooperation? Does John share the intent of the physician writing the script, or is it material cooperation? In this case, I think you could actually, when you initially look at it, you think, well, it's material cooperation because he doesn't want that to happen. But I think you could actually categorize this close to formal cooperation, because by intent, John knows exactly what's going to happen whenever he calls that pharmacy. He's intending to transfer that prescription with the knowledge that it's going to be filled. So in this case, there's a pretty high level of cooperation. What would happen, however, if John tells the woman that he cannot fill the prescription, and when she asks where she can get it filled, she simply hands him a list of other pharmacies in the area, hands her a list of other pharmacies in the area, and she leaves with that list. So this would probably be the best scenario for the pharmacist, because there's really no cooperation. All you're doing is telling her the same information she could find in a phone book. Here's the closest 10 pharmacies. However, we always think of these cases in terms of paper prescriptions. But we don't live in a paper world anymore. So in today's world, this is probably going to be an electronic prescription. Now it's in your computer system, and you can't get it out. You can't just print the prescription and hand it to the patient, right? So I think in this case, the best that the pharmacist can probably do is tell the patient, I can't fill that prescription. Still ask them what they would like to do, or give them a list of other pharmacies. If the pharmacist has to transfer the prescription, then yes, they're probably still pressing that button to transfer the prescription, or maybe the second pharmacy is calling them, but the pharmacist is not the one directing that patient to someone who they know is going to fill a prescription. So if the patient tells me, I want to go to ABC pharmacy down the street, I don't know who's at that pharmacy working today. I don't know if they're going to fill that prescription. So what I'm doing at that time is just transferring care, not referring. Does that make sense? Okay. So how can we minimize cooperation if we're working in this setting, the community pharmacy setting? Again, we talked about placing those transfer decisions with the patient. So if there is a paper script, return it to the patient. We get into trouble whenever we've had a few pharmacists in the news who've confiscated the prescription. That's the patient's property. We can't confiscate somebody's prescription. And so remember, transfer instead of refer. I always like to say, explain the reasons why you can't fill the prescription. We do a lot of saying no without telling people the reasons, and we need to be very transparent about that in a charitable way, of course. As students or people entering the profession, address these issues with the pharmacy owner before you accept a position. You don't want to get into a position later on where you're either working in a hospital or a community pharmacy, you won't fill something, and your boss had expected you to fill that. So understand that before you go into it. You could seek a position at a pharmacy associated with a Catholic hospital. There are some Catholic hospitals who have community pharmacies, and they do follow, most of them do follow at least a little bit closer to the guidelines of the ethical and religious directives, so you shouldn't be put into that position as much in a Catholic pharmacy. Or you could own your own pharmacy, and this is getting really tough in today's world as we're here to talk about religious liberty and the laws that are being put in place. But there are some examples of pharmacies in this country that are completely pro-life, and if you're a student and you want to get in touch with those people, I can certainly put you in touch with people who own those pharmacies and how to go about doing that. Other issues in community pharmacy. We hear about emergency contraception, and that's all we hear about. But there's so many other issues where pharmacists are being put into cooperation. We could talk about routine oral contraception, so the kind that is taken every day. And of course, there could be some licit uses for oral contraception, but most of the time we know it is being used for contraceptive purposes. If we don't know what it's being used for and we assume that it's being used for something licit, then the culpability on the pharmacist is probably lower. However, in community pharmacy, you get to know your patients, okay? And a lot of times you know what it's being used for. So that is an area where pharmacists are probably cooperating a lot more than they realize. Hormone supplementation to patients in a transgender state. I think this is going to be a big one coming forward because a lot of these patients are on doses of estradiol, spironolactone, or testosterone injections that are pretty similar to the doses you would give for their intended and approved indications. So, there may be, I suppose, sometimes whenever these patients come into the pharmacy and you don't know that that's what they're using it for, but most of the time you're going to know that's what it's being used for. So as a pharmacist, can you or are you going to refuse filling these just like you would refuse to fill emergency contraception? Another one is erectile dysfunction medications for homosexual patients or unmarried heterosexual patients. And I've heard physicians talk about this as well. Physicians who maybe, if they know the patient's situation, cannot prescribe these in good conscience. And so then we get to, is it our responsibility to know the indication for use? Because a lot of people will say, well, as a pharmacist, you probably don't even know what it's being used for, so therefore you don't have a lot of culpability. But I would say as a pharmacist, it is our responsibility to know what the indication is most of the time, because it's part of our job to make sure that it's being used for the right purpose. So if a patient comes in with an antibiotic, I want to know if they're treating an ear infection or an abdominal infection, because the dose might be different. The duration of therapy might be different. So I would say that it is most of the time our job to know the indication, or to at least assume it. So I don't think we can go off denying that we know what the indication is. Other controversial topics right now that pharmacists have a role in, we'll talk about all of these here in just a minute. So assisted suicide is legal only right now in Oregon, Washington, and Vermont. I expect that it's probably going to be legal soon in many states, unfortunately, because there are bills in several states right now. Current state laws in those 3 states do allow the pharmacist to refuse. This is really quite an interesting double standard, because that conscience clause is written in there in that law specifically. So in Washington State, we just talked about the case with emergency contraception. So a pharmacist in Washington State can apparently refuse to dispense a drug for assisted suicide, but not for emergency contraception. So it's quite an interesting interpretation by the Board of Pharmacy there. The American Society of Health System Pharmacists doesn't take a stand on this. What you'll see from most of our pharmacy organizations is ASHP actually has a big, long statement on this that essentially, in my opinion, says nothing. And it says the pharmacists can do what they want. So we can't really count on our secular professional organizations to help us. And then we have to think about what are the policies of our own institutions and organizations. And again, when you're the pharmacist, you may have a little bit less autonomy than the physician within your practice. So it's important to know what your organization is going to expect you to do before you start working for them. Lethal injection has become very interesting for pharmacists recently. In the past, drug companies have been able to send the product directly to the states. There was no pharmacist as the middleman. But what we've seen is that the barbiturate that was typically used in lethal injections, sodium thiopental, is really no longer on the market. So no longer being used in clinical medicine, and then Hospira, who made the drug, moved their manufacturing to Italy. And of course in Europe, they're against the death penalty in most cases. So the company quit manufacturing that drug. So then the states moved to pentobarbital. Another company ceased production of this product in part because of that reason, and now there's a shortage of that. So some states said, well, then we're going to use propofol, which of course is anesthetic that we use in surgery and intensive care units pretty regularly in hospitals. Well, one of the major manufacturers of propofol is based out of Europe as well, and they said if the United States starts using this drug in lethal injections, we're going to cut off supply to the United States. So we already had a national drug shortage of propofol. I remember the time whenever we were rationing it just a couple years ago to certain cases in the ICU and the OR. And so this created an even bigger threat to national drug shortages. So what happened now is that states are contracting with compounding pharmacies within the United States to compound the drugs, mainly the barbiturate, for lethal injection, and other drugs as well. Sometimes therapies are being used for lethal injection that obviously have never been tested in that case, and we don't really know how they're going to work. So hopefully most pharmacists will never have to deal with this, because it's still very few cases, but if you're going to work for a compounding pharmacy in the United States, it may be wise to bring this up and make sure you're never going to have to participate in compounding drugs for lethal injection. And I do want to mention that until 3 weeks ago, no pharmacy organization had a policy on this, but the American Board of Anesthesiology, American Nurse Association, I believe even the AMA, have statements against their members participating in executions. And actually about 3 weeks ago, on March 30th of 2015, the American Pharmacists Association held their House of Delegates, and as a new business item, they did pass this new policy. The original wording was much better, but I want to commend the American Pharmacists Association for at least taking a stand, and what they've said is that the APHA discourages pharmacists' participation in executions on the basis that such activities are fundamentally contrary to the role of pharmacists as providers in healthcare. So the ASHP House of Delegates is coming up in June, and a lot of times the pharmacy organizations copy each other. I'm very interested to see if anybody will introduce something like this as a new business item in our House of Delegates, the one that I'm involved in. I'm considering it, but we'll see. So let's move on to vaccines. We all know that measles has been in the news lately. This is the latest report that I pulled from April 3rd from the CDC's website. There have been 159 cases of measles so far this year. Last year, there were over 600 cases. So we can see the trend starting to go back up again. And of course, a lot of this has to do with the outbreak this year that was in Disneyland in California. So measles has been in the news, which has brought vaccinations back into the news with regard to religious liberty. Most of these cases of measles are primarily in the unvaccinated population, either unvaccinated by choice or unvaccinated because they're small infants or cannot receive vaccines. So we have to look at why do parents refuse to vaccinate their kids? And there's several reasons. Maybe they don't agree with the science, maybe they have a fear of adverse effects or just a general distrust of government intervention. And then there's the religious and moral objections. And what I hear a lot about as a pharmacist who's Catholic, I'm starting to get a lot of questions about this. It's seeping out into the public that these cell lines that are used to make a lot of vaccines are derived from aborted fetal cell tissue. And so then comes the question, should parents refuse vaccines that are produced with these illicit cell lines, or should pharmacists even stock these vaccines, and should pharmacists promote vaccination? Because we typically do promote vaccination, and most pharmacists in community settings now actually can vaccinate. So a little bit of history. Many of these vaccines were produced using these cell lines here. These are the names of them. The abortions that led to the development of these cell lines occurred many years ago, so 40 to 50 years ago. It's not currently happening. It was just a number of abortions at that time. And the cell lines have been cultured repeatedly since then. Some of the vaccines that are produced in this manner are listed here, so quite a few of them, and many of these we can't really avoid using because it might be the only one on the market. But the MMR is measles, mumps, rubella. That's the one in the news right now, of course, and it's actually the rubella component of this that's produced with these cell lines. And in the past, Merck had made a different vaccine, a measles, mumps, with the rubella separate. But when they decided to combine all three of these, now the parents can no longer get the measles vaccination without also getting the rubella vaccine. Other ones, chickenpox, hepatitis A, polio, rabies vaccine, shingles vaccine, and now the new Ebola vaccines are being produced with these cell lines as well. So can parents give these vaccines? We talked earlier about the different levels of cooperation with evil, and I think it's it's nice that we actually have guidance in the form of a correspondence from the Pontifical Academy for Life in 2005, and they've determined, rightly so, that this is very remote immediate material cooperation if parents or even if pharmacists and physicians are using these vaccines. So there's a very extremely small level of cooperation, which means that if there's a proportionately good reason to use these vaccines, then we can licitly use them and without harm to our conscience. However, they did note that we do have a duty to use alternative vaccines if they're available, as well as we have a duty to give our objections. So either contacting the drug companies or legislators or the CDC, FDA, and voice our concern with this. So when very serious diseases could be prevented, the obligation to vaccinate may actually be higher than the obligation to avoid illicit therapies or these vaccines produced illicitly. And so we know that the risk to public health is pretty high from some of these diseases. What is our responsibility as pharmacists? I think as pharmacists, as well as physicians, other healthcare providers, we do have a bigger voice with industry than the general public does. So we do need to make sure that others know that this is out there, and we don't want especially new vaccines being produced in this way. We need to educate other healthcare professionals. I can't tell you the number of pharmacists that I've spoken to. We talk about vaccines and they say, well, what do you think about religious objection? And they're thinking about Christian Science, religion, and when I tell them about this, that many of them are produced with cell lines that come from aborted fetal tissue, they have no idea whatsoever. So they're very surprised. I've actually had a drug rep in my office who didn't know that either from one of these companies, and the look on her face was very interesting whenever I told her that. So our job is to educate and get the word out, but not to discourage people from getting these vaccines. And our job as pharmacists is to use those alternative products where available, and sometimes there are alternatives available. These are just 3 examples. So with the rabies vaccine, there's 2 products on the market, Imavax and Rabivert. In my hospital, we order Rabivert because it's not produced with these cell lines, and it's virtually interchangeable and the same price. So we can avoid those products in some cases. These others are not vaccines, but other drugs, glycoprotein 2B3A inhibitors. ReaPro is the one that is produced using those fetal tissue cell lines. Integralin is not. So in cases where the indication is such that we could use Integralin, we should. And with rheumatoid arthritis, for example, Enbrel is produced using the fetal cell line, and Humira and Orencia are not. So we need to be aware of when we can use other products. So how does the vaccine debate relate to religious liberty? We talked about pharmacists as well as parents mostly who want to refuse these vaccines. And we get to many states now who are trying to, as a result of the measles outbreak, regulate the objections more. So California Senate Bill 277 is in debate right now, and this would remove the religious and personal exemptions for refusing vaccines in public school children. So the only exemption that would still be available is a medical exemption. So we've said that, both states and Catholics have an interest in promoting the common good, and we can receive these vaccines. But when we're talking about these kinds of laws being put in place, there's a big fear that these laws will impinge on the religious liberty of parents. We're going to shift gears here. I know I'm skipping around a lot, but I wanted to try to cover several different topics that pharmacists are involved in that are not just emergency contraception. So end-of-life care. Pharmacists have a big influence in end-of-life care. We work in hospitals, we work in hospice settings, in infusion services where we're making infusions for patients. We work in long-term care settings. So with end-of-life care, pharmacists can primarily influence 2 areas, pain management as well as nutrition and hydration. When we talk about pain management, I want to tell a story about a stealth case of possible stealth euthanasia, and I hope this doesn't happen as very often. But I was in conversation with a colleague of mine, I'm not going to say where he's from, somewhere in the United States, and we're talking about this, and I said, have you ever seen stealth euthanasia? Have you ever seen where a physician has tried to prescribe something that you thought was too high of a dose? And I thought he's going to say, oh no, I've never seen that. And he says, oh yeah, I've seen that. And so I said, tell me about it. And he said, well, we had a patient in the intensive care unit who had been here something like 6 months, was kind of festering, but he hadn't been on any opiates for a while. He'd been pretty stable, hadn't needed the pain medicines. And then the family decided to make him comfort care and remove extraordinary means of life support. And then all of a sudden I got an order for 60 milligrams of morphine times 1. And I said, wow, what did you do with that? And this is back in the age of paper. And he said, well, at first I thought it was, the physician is supposed to be 6.0 and he's using one of those trailing zeros, those unapproved abbreviations that we're not supposed to use. So I called to clarify, but the doc said, no, that's what I want, 60. And I said, well, what did you do with that? And he says, well, I wasn't going to dispense that. I called the chief medical officer and he handled it. So unfortunately, I think some of these cases are happening, and I think that's where pharmacists can really play a big role in helping. In most cases, I really don't think the physician's doing it on purpose. In this case, maybe he was, but a pharmacist can play a big role in helping to determine where we can manage the patient's pain at the end of life appropriately without being too high of a dose for that individual patient. And like Dr. Perucci said earlier, this isn't something, obviously, where you can say exactly what dose that is. It's very individualized for the patient. Nutrition and hydration is another area. I know that Father Blasek was just telling me earlier in his experience in the intensive care unit how much pharmacists helped out with TPNs, total parenteral nutrition, and we do a lot of consults unofficially typically in the ICU as well as in infusion services and home care in nutrition and hydration. So this is an area where we can really help guide at the end of life when it would be appropriate to stop nutrition and hydration and when it's not. In my role now, I haven't been in clinical practice in almost 6 years, which is hard to believe. I really miss it, actually. But as a director of pharmacy and in pharmacy management, there are other issues that we face, too, that you wouldn't normally think about. You know, you go into management and you think, oh, great, I'm not on the front lines anymore. I don't have to deal with these ethical issues. And then you realize, uh-oh, this invoice just came across my desk and it has a drug on there that is not ethically appropriate. And so these are the issues we primarily deal with. In acquisition of medications, there are various issues of cooperation, and I think we have to think about here, what is our certainty as a manager that the medication that we're acquiring is going to be used for an illicit purpose or illicit purpose. So we would have much more cooperation in the act if we're ordering something like an abortifacient, which is pretty much always used for that indication, as opposed to much less cooperation if we're ordering things like hormones or opiates that are typically used for illicit purposes, but occasionally at our hospital they may be used for other illicit purposes that we, not being on the front lines, don't even know when that is. Then there's what I mentioned before, paying invoices. And the invoices come across my desk in an electronic queue. I get probably 30 a day, because I have several different pharmacies, and on some of those invoices there may be, the biggest one for the hospital, there's probably 50 drugs on one invoice, all listed, and honestly, you don't go through them one by one, right? You're looking for trends, you're looking for, did the buyer spend a lot of money on something and I need to know about what that was, or did we order more controlled substances than we should have? But when the invoices come across, if it's a single invoice that just has one item that we would consider illicit, such as an IUD for an OB-GYN clinic, then I think there's going to be much higher level of cooperation because you know exactly what you're paying for. Versus if there are many items on the invoice and one of them might be used for an illicit purpose, but all of the other items are used for an equally good purpose, maybe as a proportionate reason you could say, well, I'm just paying these bills for drugs that have probably already been used at this point. I didn't know that they were coming into my institution many times. And that possibly could be tolerated if there are other drugs on there that are just as used for just as much of a good purpose as the illicit drug is for a bad purpose. How could we minimize this cooperation, though? If you're in one of these institutions, it's possible you could get somebody else to approve the invoices, but I think it's important that that person needs to be either an equal level or superior, because otherwise, you know, my assistant director of pharmacy is also Catholic. So if I say you're going to approve these invoices, then what kind of position am I putting him into? And then when you're a manager, oftentimes you have much more influence than you realize. So when the hospital creates new policies, you have a big impact in how those policies are created. So in my hospital, I've been involved in policies on emergency contraception and end-of-life care, including nutrition and hydration. And I have a friend at a different hospital. This hospital was getting ready to set up a hospice program, and she was the only pharmacist on the committee to determine, you know, how this program was going to be set up. And she was able to make sure that the policies and procedures for that hospice program with regard to end-of-life care were appropriate. That was actually a Catholic hospital, so she was instrumental in helping with that. The circle of influence outside the job when you're in management is pretty big as well as, like I said, I've been in the House of Delegates for ASHP, and this is a place where not only pharmacy managers, but all pharmacists, different types of pharmacists in the House of Delegates, but I think especially when you're in management or you're involved in these kinds of decisions, you tend to get involved also in legislative issues or professional organizations, and that's a place where we can have a really big impact as pharmacists. So in summary, today we've talked about several different religious liberty cases affecting pharmacists. We've talked about some state laws and positions of professional organizations. what exactly is referral and the basics of principles of cooperation with evil, and looked at some different scenarios, as well as some strategies to minimize cooperation as a pharmacist. And at this time, I'd entertain any questions.
Let's give her a hand for a wonderful presentation. So we'll open the floor to questions. Again, I would ask that you wait till the microphone come within your reach so that we can capture it for our podcasts that we're putting out. And actually, we're going to ask people to come a little bit forward in the room to ensure that the microphones are in range of their receivers. So are there any questions?
As a physician, I'm approached by an unselected group of patients, sometimes on the street, that want Viagra. You got any?
I'm sorry.
In regard to Viagra, has any problems ever, aspects of that entered your mind?
Sure. Well, the Viagra and drugs, other drugs in the same class, aren't necessarily illicit in and of themselves if they're being used to support the intended role of within a marital relationship. So I think that that's one of those drugs where it really depends on the situation that the patient is in. Now, if we don't know, as a pharmacist or a physician, if we don't know their situation at home and we assume that they are in a traditional marital relationship between a man and a woman, then I think we can safely say we're not culpable in that evil. But if we know that they're in a relationship that is either homosexual or even an unmarried man and woman, then that's where it becomes a larger cooperation with evil on the part of the pharmacist or the physician prescribing it.
Warren, could you come up to be a little closer to the receiver?
Great talk. Is this on? Hello? So my question had to do with the discussion of the various organizations' positions on involvement in executions. Mm-hmm. And I was wondering if you could clarify if the position against participating was motivated because of disagreement about the morality of executions in general, if it's like there's some fundamental opposition to that, or if it was more a conflict of our oath as physicians to do no harm, and that it's more related to that conflict of we're supposed to be providing care, not killing people.
Yeah, I can't speak to the physicians' organizations as to why those came about there. What I can talk about is the American Pharmacists Association, which just happened a few weeks ago. And I believe that in that case, it was what you're saying, that it's just, I don't think there was a big discussion of getting into cooperation with evil and all of that. I think it was just, this is really in contrast to what we are as pharmacists. And it would be the same for physicians as far as, our job is to heal, not to kill, essentially, which is interesting because some of these same organizations then won't take a stand on other aspects of killing or other types of killing. So, yeah.
If I may ask a follow-up question. Mm-hmm. So if it's not a pharmacist dispensing this to somebody who's being executed, who is that person and how are they trained to do it in a way that would be quote-unquote safe or effective?
Mm-hmm. It depends on the state. In some states, I think it is a healthcare professional who's actually administering the drug, but in other states it's not even a healthcare professional. And there have been cases, I believe Oklahoma was one where there, you hear of botched executions, and a lot of times the drug is infiltrated into the patient's arm because the IV wasn't set up properly. So there are those issues as well. In my opinion, any way that we can get at no more executions would be a good thing. If we're getting at it by the fact that we don't have good drugs to use for it, then I'm okay if that's the mechanism that we get there. But where the pharmacist comes in, they're not, of course, the ones actually administering the drugs, but they would be compounding some of these drugs, and because the states can no longer get them directly from the companies. It was very interesting. I want to go back to what I was talking about with APHA. and I missed this, but it sounds like we don't have very many pharmacy students here, but I actually moderate a Facebook group for Catholic pharmacists and pharmacy students, and we have discussions, various discussions. Sometimes pharmacy students will come on there and say, you know, I want to practice according to my Catholic faith, how do I do that? And other pharmacists will respond. It's really pretty neat. And when the American Pharmacists Association had this proposed to the House of Delegates 3 weeks ago, one of our Facebook group members was there and a delegate, and she posted the initial language, and we all got to comment on it. And then she posted when it passed, so we knew immediately when this was going on, and other pharmacists were commenting on it who weren't even in the House of Delegates. So it's been, I think it's been good for me. I think it's been good for a couple of other pharmacy students at least that I've talked to who have found it helpful. So if you know pharmacy students or pharmacists who might like to join our group, just have them search on Facebook for that.
I'm not sure I have a question, but I'd like to comment on that last question, if I could. The last question was about what the motive was for the anesthesiologists to object to participating in executions, and it doesn't really matter whether it's a religious motive or an ethical motive, and I think that it's an important point that it doesn't matter, that it shouldn't matter. This Hobby Lobby decision recently that carved out a religious exception for certain family-owned companies, you know, that's headed for trouble as well, because it shouldn't matter what your objection is. Mm-hmm. And I think it was Missouri where they wanted an anesthesiologist to be in attendance at executions, and they passed a law in that regard, and they started looking for anesthesiologists, and anesthesiologists said, well, you know, I'm not going to do that, go look for somebody else, and pretty soon more and more anesthesiologists were individually making individual decisions, saying, well, you know, I don't want to do that. Ask somebody else. And eventually it got to the point where the state of Missouri couldn't find any anesthesiologists to do it. Despite they started threatening them with licensure, and that's when the organizations started getting involved, saying, well, you know, you can't do that. So it's an important principle for professionals. A principle of bioethics is that ethical behavior is not determined by you know, any code of conduct or what the Pope says. Ethical behavior ultimately is determined by whether you can get people to do stuff. And that's why conscience laws are so important to learned professionals.
Would you like to make some response to that, or will we let it stand as a proclamation?
We can let it stand, I suppose, but I think you're right. It was Missouri with that. I remember hearing about that now, and Missouri actually has executed something like 15. It's one of the highest states for executions in the country, so we have a lot going on with it in Missouri right now. Thank you.
There's a question back here. Can you come a little closer to the front?
Hi, thank you for your talk. I thought your point about referral versus transfer of care was really interesting, but it led me to thinking about what you do in an emergent situation where the transfer of care may, while be completely morally acceptable on the healthcare provider's part, may lead to harm or a decrease in probability of, you know, safely being alive for the patient when you wait for someone else to come in and take care of them.
That's a tough one. Can you give me an example of emergent situation that you're thinking of?
So I'm a lowly M1 and don't know much about drugs, I admit. But I was thinking of, you know, there's a lot of religions that don't like using porcine elements in drugs.
Okay.
And so, porcine or gelatin things. So if someone needed, we don't use pork-based insulin anymore, I don't think. I know, it's tough. But we do use gelatin in a lot of capsules. And so if someone was against using gelatin at all, but a patient needed it to be alive, and waiting for that transfer of care may take time away, which could harm them, what would you do?
Okay, so in that example, I'm having a harder time with, because there's probably not another product I can use. So I think in that case, then the patient's surrogate is going to have to decide if they want to use that product or not. I'm really having a hard time picturing with pharmacy practice what types of emergencies there may be. I guess one that I might think of would be, let's put ourselves in a hospital pharmacy environment, and a patient comes in for a C-section, and at the same time they're going to have a C-section, the physician's going to perform a tubal ligation. So maybe this might be the situation you might be talking about, and you're the only pharmacist on duty that night, and you're going to be preparing the medications needed for the C-section. So that's a tough case. I think that, you know, that's probably more along the lines of maybe immediate material cooperation, because you know that those drugs are necessary for the surgery. You do have, the C-section may be necessary, maybe it's an emergent C-section or something. But then afterward, you probably have to try to figure out how to not put yourself in that situation in the future. It's pretty difficult in that kind of situation, but I'm having a hard time thinking of very many emergencies from the pharmacy side.
I can speak to the emergent ER. We have something called EMTALA laws, which basically, even in an emergent situation, you treat the patient, period. You keep them alive. You then deal with the ramifications of what you do. But ER situations where you have to get someone to a center that can handle it if yours can't, that's all covered by law. That absolutely has to happen. And when you don't have other choices of what other meds to do, our country, despite all the other bizarre, interesting arguments going on, still says keep the patient alive. And that gets pretty straightforward pretty quickly. Something has to.
Any other questions from the back of the room? I have, we'll come to you in just a moment, and then I have one first, if I may, which touches, we've talked a lot about moral theology, particularly as it touches on culpability. I have just a question touching on justice and the pillars of justice, and maybe any of your experience, either as an administrator or in clinical practice, on access for the poor to pharmacotherapy, consultation, products. Could you make some general or specific comments on that?
Sure, I think, so the question is about access to medications for those who can't afford them, basically. You know, I think that in pharmacy, it's a little bit different, because if you're talking about hospital pharmacy, you really don't have an issue there. It's the same as what Dr. Perucci said. We don't even know what the patient's insurance is in hospital practice. In community pharmacy practice, it's a little bit different because you expect to get paid for that. I think that more and more pharmacists, though, are helping patients with ways to access medications, whether it be helping. There's a website called Needy Meds, and a lot of times the social workers will use this, but pharmacists are using it too to help patients get enrolled in assistance programs. I know one pharmacist in my town who owns an independent pharmacy, and if it's a medication that's truly a life or death type medication, he told me just a few weeks ago, he said, you know, some of these patients I know I'm never going to get paid, but that's just part of our business model. So there are pharmacists who've started to try to incorporate.
11:30.
This keeps telling me what time it is. There are pharmacists who are starting to incorporate into their practice models, how do we take care of those patients who come in and can't afford those medications? So.
Thank you again for your wonderful talk. Talking about Pope Francis and his approach today about actually being open to work with and journey with people, anyone, where he says, in essence, who am I to judge? And so the whole issue of confidentiality and actually being able to provide these types of medications for patients, say a transgendered person, perhaps who has a suicidal history, that really this would help change their life to be able, for them to be able to actually grow into the living Word of God. Is it possible, that you feel that pharmacists can have a role to play in that kind of prophetic and personalized approach to being open to individuals in that kind of situation?
Sure. It's not, I think we get too caught up in refusal, like I won't do something, and we need to talk about what we can do. And I think that Dr. Perucci touched on this earlier, but a lot of this is going, in religious liberty debates, is going to be phrased in the term discrimination later on, or now. But we have to remember we're not discriminating against the person, but the act. So for example, that transgender person comes in for their diabetes medication. Obviously, you're not going to send them away because they're transgendered. You're going to treat their diabetes. But rather, when it's a medication relating to the act, which is evil, then that's a different story. But I do think there's a role for pharmacists. Some community pharmacies, you get to know your patients so well, it's like a beauty shop. It really kind of is. And I haven't practiced in that setting, but under me, there's a couple of pharmacies, retail pharmacies that report to me, and I'll get calls from one of the pharmacists that says, well, did you know such and such? And I'm like, I go to you for all the gossip because you know it. But what I'm saying with that is that you get to know your patients so well that I think there's definitely a role for that type of evangelization and showing mercy to those patients even though you can't support that evil act. Yes.
Let's give a hand for a very useful and informative presentation. We're going to take a moment here to either take for the first time or to re-administer a healthcare provider's oaths, and recognizing that there's many different kinds of or different ways to provide health care, to be a practitioner. You can take a look. We have the Oath of Hippocrates, and we also have the Declaration of a Healthcare Provider. And I will administer those. We'll recite them together, whichever one you feel more comfortable taking. Before Dr. Schorsch moves from the back of the room, though, I just want to draw your attention. If you look, Dr. Al Schorsch is going to be taking over the Integritas Institute this summer. I had the pleasure of leading it for 2 years. He has just retired from a deanship in the College of Urban Planning and Public Affairs, no stranger to the University of Illinois Chicago and its administration, nor to Integritas. He has been on our board of advisors for many years, and so we're extremely grateful for his availability and excited to have him. I think if any of you might want to introduce yourself to him, particularly to have continuity of relationships as I move off to Louisiana to one of our retreat houses. And let's give Dr. Schorsch a hand as well. So that being said, if there's any physicians present or any others who want to take the Oath of Hippocrates with us, I'd ask you to stand at this time, and then immediately after that we'll recite the Declaration of a Healthcare Provider for those who would categorize themselves more particular that way. The Oath of Hippocrates, and we'll say this together. I swear in the presence of the Almighty and before my family, my teachers, and my peers, that according to my ability and judgment, I will keep this oath and stipulation, to reckon all who have taught me this art equally dear to me as my parents, and in the same spirit and dedication to impart a knowledge of the art of medicine to others. I will continue with diligence to keep abreast of advances in medicine. I will treat without exception all who seek my ministrations, so long as the treatment of others is not compromised thereby, and I will seek the counsel of particularly skilled physicians where indicated for the benefit of my patient. I will follow that method of treatment which, according to my ability and judgment, I consider for the benefit of my patient, and abstain from whatever is harmful or mischievous. I will neither prescribe nor administer a lethal dose of medicine to any patient, even if asked, nor counsel any such thing, nor perform act or omission with direct intent deliberately to end a human life. I will maintain the utmost respect for every human life, from fertilization to natural death, and reject abortion that deliberately takes a unique human life. With purity, holiness, and beneficence, I will pass my life and practice my art. Except for the prudent correction of imminent danger, I will neither treat any patient nor carry out any research on any human being without the valid, informed consent of the subject or the appropriate legal protector thereof, understanding that research must have as its purpose the furtherance of the health of that individual. Into whatever patient setting I enter, I will go for the benefit of the sick and will abstain from every voluntary act of mischief or corruption, and also from the seduction of any patient. Whatever in connection with my professional practice or not in connection with it, I may see or hear in the lives of my patients, which ought not to be spoken abroad, I will not divulge, reckoning that all such should be kept secret. While I continue to keep this oath inviolate, may it be granted to me to enjoy life and the practice of the art and science of medicine with the blessing of the Almighty, and respected by my peers and society. But should I trespass and violate this oath, may the reverse be my lot. Thank you. So if you'd be seated, and if anybody prefers to make the declaration of a healthcare provider, I'd ask you to stand at this time as well. And we will recite this together as well, a declaration of a healthcare provider. Now, as a healthcare provider, I solemnly promise that I will, to the best of my ability, serve humanity, caring for the sick, promoting good health, and alleviating pain and suffering. I recognize that the practice of medicine is a privilege with which comes considerable responsibility, and I will not abuse my position. I will practice medicine with integrity, humility, honesty, and compassion, working with my fellow doctors and other colleagues to meet the needs of my patients. I shall never intentionally do or administer anything to the overall harm of my patients. I will not permit considerations of gender, race, religion, political affiliation, sexual orientation, nationality, or social standing to influence my duty of care. I will oppose policies in breach of human rights and will not participate in them. I will strive to change laws that are contrary to my profession's ethics and will work towards a fairer distribution of health resources. I will assist my patients to make informed decisions that coincide with their own values and beliefs and will uphold patient confidentiality. I will recognize the limits of my knowledge and seek to maintain and increase my understanding and skills throughout my professional life. I will acknowledge and try to remedy my own mistakes and honestly assess and respond to those of others. I will seek to promote the advancement of medical knowledge through teaching and research. I make this declaration solemnly, freely, and upon my honor. Thank you, and congratulations to any who make that for the first time. Well, with purity, holiness, and beneficence, let us adjourn to lunch, and we'll return here for the third talk and after taking some time to enjoy the meal.